Hi there. I'm Dr. Keri Chaney, an assistant professor of dermatology at the Medical College of Wisconsin. I'm delighted to be invited by the Cutaneous Lymphoma Foundation to share this presentation with you on the basics of cutaneous lymphomas. As an overview of my talk today, we're going to start by discussing lymphomas. What is a lymphoma? What are the types of cutaneous lymphomas? And how does my doctor diagnose a skin lymphoma? We'll review staging, what it is, what tests need to be done, and how they're done. I will also speak specifically about staging of mycosis fungoides and Sézary syndrome, as these are the most common cutaneous lymphomas that we see here in the United States. We'll very briefly go over prognosis of cutaneous lymphomas and also some of the treatment options that are available for patients. So starting out with how we make a diagnosis. A diagnosis is naming the problem and telling where it came from. And we name cancers by the type of cell that they come from originally. So a lymphoma is a cancer of the lymphocytes, and the lymphocytes are a type of white blood cell. We'll discuss that more later. I also want to mention that leukemia, which you may hear me mention as well, is also a cancer of white blood cells, but this occurs when the abnormal white blood cells or cancer cells are present in the bloodstream or bone marrow. Sézary syndrome, which you'll also hear more about today, is a form of leukemia of the T lymphocytes. So as I mentioned, lymphocytes are a type of white blood cell. So white blood cells are part of our body's natural defense against infections and cancers. You can see here on my slide that there are many different types of blood cells. There are red blood cells, which help carry oxygen to the body. There's platelets that help us with blood clotting. And then there's a variety of different white blood cells that are our defense system. So over here, I'm going to draw your attention to the two main types of lymphocytes, which are the B lymphocytes and T lymphocytes. So we define these lymphocytes by the types of proteins they make and attach to their cell surface. So B cells have what's called the B cell receptor, and T cells have what's called a T cell receptor. And that is how we recognize which cells these are. Now, lymphocytes are found throughout the body. They are in our bloodstream and they're in our lymphatic system. And the lymphatic system consists of a number of different organs. So there are lymph nodes, which are present in these little green clusters, which are all throughout the body. And lymphocytes are also found in our bone marrow. That's the inside of our bones where blood cells are made. They're in our liver, our spleen, and our thymus, which is a gland that is more present in children and sort of atrophies as we get older. But as a dermatologist, I want to highlight that there are many, many lymphocytes in the skin as well. There's actually more T lymphocytes in our skin than there are in our bloodstream. And those T lymphocytes circulate through our skin and through our body as our police force or our army, protecting us from germs, especially viruses, and then also protecting us from developing cancers. But when these lymphocytes multiply out of control, a cancer forms. So one note about Hodgkin's lymphoma. So historically, Hodgkin lymphoma was the first type of lymphoma that was recognized by doctors when they were looking at tissue under the microscope. And so anything that was not a Hodgkin's lymphoma was labeled as non-Hodgkin's lymphoma. So virtually all cutaneous lymphomas are a form of non-Hodgkin lymphoma. And here in the United States, there's many, many different types of lymphomas that are diagnosed each year. And there's about 80,500 new cases of non-Hodgkin's lymphoma diagnosed. And that includes both adults and children. Now, cutaneous lymphomas make up only about 4% of non-Hodgkin's lymphomas. So roughly speaking, in 2022, there will be about 3,220 new cases of cutaneous lymphoma diagnosed. And in the United States, most of our cutaneous lymphomas are T cell lymphomas as opposed to B cell. There's probably at least 3 times as many T cell lymphomas as there are B cell lymphomas. Now, you're probably wondering what may cause cutaneous lymphoma. And unfortunately, we do not have a great answer for that. Now, when we look at lymphomas as a whole, there are a few risk factors. So people with weakened immune systems, now if that's from a medication that's suppressing your immune system, from another illness like an autoimmune disease, another cancer, and then some genetic causes. There are certain infections that predispose people to some types of lymphomas and some toxic exposures. For example, things like Agent Orange in the military in Vietnam, and firefighters have an increased risk of lymphomas. However, when we look at cutaneous lymphomas specifically, they are not hereditary. We don't see them running in families. There's no direct genetic cause, meaning we can't find a mutation in one gene in your DNA that causes the cutaneous lymphoma. And they're not caused by an infection. They're not infectious, so you can't spread them to anyone. And we have not found any specific toxic or environmental exposure that will lead people to develop cutaneous lymphomas. Now, as I mentioned, there are a lot of different types of cutaneous lymphomas and lymphomas in general. And we usually group the skin lymphomas into the T-cell lymphomas and the B-cell lymphomas. And just as I mentioned, there's lots of different types. The treatment and the prognosis can vary very considerably among the different types of lymphomas. So it's really important to know your subtype and know that not all information on lymphomas will generalize to your specific condition. So here is a long list of some of the many different types of cutaneous lymphomas. We'll look at some of these a little bit more in detail. So as I mentioned, the T-cell lymphomas are the most common cutaneous lymphomas in the United States. The most common forms of cutaneous T-cell lymphoma are what we call mycosis fungoides and Sézary syndrome. Over here, I have pictures of mycosis fungoides, which starts as scaly lesions or sometimes tumors in the skin, and Sézary syndrome, which is a leukemic form. Again, that's where the abnormal lymphocytes are in your bloodstream, and it's characterized by diffusely red scaly skin all over the body with enlarged lymph nodes, hair loss, and a few other features. Now, there's another form of cutaneous T-cell lymphomas called the CD30 positive lymphoproliferative disorders. This includes an entity called lymphomatoid papulosis, which is not really a cancer, and then other tumors and forms of cancer called anaplastic large cell lymphoma. B-cell lymphomas look a little bit different. There are three main types that we see in the skin, including diffuse large B-cell lymphoma, most of which is called the leg type, primary cutaneous marginal zone lymphoma, and primary cutaneous follicle center cell lymphoma. And these tend to be red or skin-colored bumps. Many of them start on the head or neck region, and sometimes they start out looking like a bug bite or a pimple that just grows and doesn't go away. Now that we've seen some different types of cutaneous lymphomas and discussed some of those subtypes, how do your doctors go on to arrive at a diagnosis? So the main thing that needs to be done is a skin biopsy. Most of the time that's done by a dermatologist, but sometimes it's done by oncologists or primary care doctors. And to do a biopsy, usually what a doctor does is they numb up the skin using an injection of lidocaine or another anesthetic. They use a little tool called a punch biopsy that's like a small cookie cutter that takes a very small piece of skin. The skin is removed. Sometimes a stitch is put in. And there's other ways of doing biopsies too. But then that biopsy goes off to the lab to see what they can find out about it. So the biopsies go to a pathologist, and that's a medical doctor that studies tissue. And there's a number of different tests that are done. So it's very difficult to get these results overnight or in a few days because it takes time to do these. So we'll talk a little bit about some of the tests that are done. One is called histology or histopathology. Then there's another type of testing called immunohistochemistry. And then there's even more complicated, sophisticated molecular studies that are done, things called T-cell gene rearrangement studies, IgH gene rearrangement studies. And the most recent test that we've added to our toolbox is something called high throughput TCR sequencing. So histology or pathology is the study of tissue or the study of abnormal tissue. So the pathologist looks at the cells that they see. So this is an example of a lymphoma. And they look at the cells themselves and whether those cells look abnormal. And then they also look to see if the arrangements of the cells is abnormal. And we call that the architecture of the tissue. Then we go on to immunohistochemistry, and that uses antibodies to help us decide what kind of cells are present. So if you're looking at one of your own pathology reports, oftentimes you'll see some of these proteins that are named CD and then a number. So for example, CD19 and CD20 are markers that help us find B lymphocytes, and CD3, CD4, and CD8 are some of the markers that label T lymphocytes. So deciding whether these proteins are present or not present helps us decide what kind of cells are present in the tissue, and then if they're acting in a normal or abnormal way. Then there's some other markers that can be interesting to help us with both diagnosis, prognosis, and treatment. For example, there's a protein called CD30 that can be found on both T and B cell lymphocytes. It's also one of the defining characteristics of that form of T cell lymphomas that we call the T cell lymphoproliferative disorders. And then there is a special treatment, an antibody that is linked to almost like a chemotherapy agent called brentuximab vedotin. And that's an immunotherapy medicine that kills any cells that express CD30. Now I want to briefly mention these more sophisticated molecular tests that we use called T cell receptor gene rearrangements. And the purpose of this is to look for clones in your biopsy or your sample. So a clone is an exact copy of a cell or an entire organism. So some of you may remember when Dolly the sheep was cloned back many years ago. Or some of you may be Star Wars fans like they are in my house, and that you may be familiar with clone troopers. So cancers all contain clones. And a lot of time cancer cells are descendants of a single abnormal cell that then replicates itself over and over again. So in our biopsies or blood work, we're looking for lymphocyte clones to help us make the diagnosis of a lymphoma. So as I mentioned, all cancers are cloned or clones of one another, but not all clones are cancer. So in some benign skin conditions like drug reactions or even eczema, we may find clones, and that does not make it a cancer. So when we're looking at T cell lymphomas of the skin, what we're looking at are there clones of those T cells? And the way we do this is by looking at the T cell receptors of the cells. So a T cell receptor is a specific molecule that is on the surface of that T lymphocyte. And this is the tool that the lymphocyte uses to bind to abnormal cells, to germs, and then it uses that to activate the immune system to destroy that invader. So here is the T cell receptor of this T cell binding to something that should not be in your body. Now, all T cells have slightly different receptors so that they can identify many different things. Something that identifies the coronavirus is going to be different from something that identifies the chickenpox virus. Just like you have many different keys to unlock different doors, T cells have different receptors to identify different pathogens. But a T cell clone will all have the exact same receptor. And so we are able to do studies by looking at the DNA in these cells to see if there's clones. So we take the sample, either skin or blood, and then we isolate the DNA from that. And then we use a process called PCR to amplify the DNA to see if there are clones of the DNA in many different cells. Now, if we're trying to diagnose a B cell lymphoma, we can look for clones there too. Instead of looking at the T cell receptor, we look at the immunoglobulins that the B cell makes. B cells make antibodies. That's their main job. So there are different parts of the antibody, especially this heavy chain, this larger part of the antibody that we can amplify to see if those are clones. Now, so after all of these tests, if the cells in the biopsy look like cancer when we see them under the microscope, if the immunohistochemistry, all of those tests looking at the type of lymphocytes, if that's typical of a lymphoma, and if there's a clone, we can make a diagnosis of a cutaneous lymphoma. However, this is not always straightforward. And some of you may know that you needed multiple biopsies and possibly over even a variety of years to make the diagnosis. So this is not uncommon. Doing a biopsy of a spot that has not been treated sometimes may help us make this diagnosis faster. Oftentimes, if you're putting topical steroids on a skin lesion, it makes it harder to make that diagnosis. So once we have the diagnosis, we move on to staging. So staging helps us define where the lymphoma is located. Is it just in one place? Is it just in the skin? And that helps us determine the prognosis of the cancer, and then also helps us determine what treatment would be appropriate. So there is a standardized system for defining the extent of cancers, and it's called the TNM system. And for cutaneous lymphomas, we also look at B, which is the blood. So T stands for the tumor. How many lesions are there and what extent do they cover? N is looking for the lymph nodes. Is the cancer present in the lymph nodes or not? M is for metastasis. And a metastasis is a tumor that has spread to a completely different organ. So for lymphomas, that may include the lungs, the liver, the spleen, the brain, or other organs. And then B is looking at the blood to decide if there's cancer cells there as well. So I'm going to discuss staging of mycosis fungoides and Sézary syndrome. Unfortunately, I can't discuss the other staging systems. They do exist. There is a TNM system. However, it doesn't give us any information on prognosis. Like I said, each lymphoma is different. Each lymphoma has a different prognosis. And for some of these lymphomas that are quite rare, they don't have their own staging system. We have a staging system that helps doctors divide patients into groups on whether the cancer is localized in one area or if it's spread throughout the body. But unfortunately, that doesn't give us information on prognosis. So when we deal with mycosis fungoides and Sézary syndrome, to figure out the T, that is done by the eyes of a doctor, especially a dermatologist. So we look at the type of lesions that we see and we describe them and we see how many there are and how much of the body it involves. So T1 is when there's either patches or plaques covering less than 10% of the body's skin surface. So a patch is completely flat. A plaque is very slightly elevated, like a small plateau on the skin. And 10% of the skin surface, if you want to know how to estimate this, if you look at the palm of your hand, that's approximately 1% of your skin surface. Now, T2 is patches or plaques covering more than 10% of the skin surface. T3 is when there's tumors present, and a tumor is about as deep as it is wide, or it's much deeper than a plaque would be, and they need to be at least 1 centimeter in size. Finally, we have T4, which is erythroderma, which means there's redness and scaling covering at least 80% of the body. So here's some examples. T1 of patches or plaques. These appear to be plaques covering a limited amount of the skin. T2 is when you have patches or plaques covering more than 10% of the skin. T3 is when you have a tumor, a lesion that is almost as deep as it is wide, and it's at least 1 centimeter. And then T4, which is erythroderma, red scaly skin covering at least 80% of your body surface area. Then we move on to the N and the M. N is looking at lymph nodes to see if they're abnormal, and M is searching to see if there's any metastasis or cancer spread to other organs. We do this through physical examination. So we'll feel for enlarged lymph nodes in your neck, under your arms, in the groin area. We can also feel to see if your liver or your spleen is abnormally large. And then we use different types of radiology to help us look into the areas that we can't feel. So these include CT scans and PET scans. Then if abnormalities are found, usually we may need to do a biopsy to confirm that the abnormality that we find is actually cancer. So with the N's, we grade that on a scale of 0 to 3, depending on if there's lymphoma in the lymph node or not. And N is graded as either a 0, meaning no metastases, or 1 when there's metastases present. So a CT scan, also known as a CAT scan, that stands for computerized axial tomography. That's a test that uses X-rays in a computer to generate pictures of the inside of the body. It allows us to look at your lungs, at your liver, at your lymph nodes, and see if things are enlarged or if they're abnormal. A PET scan is a little bit different. The PET stands for positron emission tomography. And that is a test that uses radioactive glucose, which is the main food of all of our living cells, to identify if there is cancer in the body. So glucose is the fuel that all of our cells run on, and cancer cells are dividing more actively and require more glucose than many of our other types of cells. So in this PET scan here, you can see that we can use this scan to identify cells that have more glucose that they take up and therefore are darker. Now, there are some normal cells that take up a lot of glucose, like your brain and your kidneys. However, that's normal and we understand that. But then we do see the lymphoma present in lymph nodes. Here, this is actually under someone's arm, and here in the pelvis as well. Finally, we look at the blood, and there's a variety of different tests we can do. The main one we do is called a CBC, or a complete blood count. And that looks at your red blood cells, your white blood cells, and your platelets, and tells us how many they are. That doesn't tell us if they're abnormal, but we do get to see if there's an increase or decrease in what we expect to see. Then there's another test called flow cytometry, which can be done on blood or even tissue, and that's counting and sorting the lymphocytes. So we use those proteins that they make to sort them into groups and decide if there are abnormal cells present. So if this grouping over here are lymphocytes from a patient with Sézary syndrome, they will have normal T cells, and there's two different types that we talk about mostly, CD4 cells and CD8 cells. And then we will have the Sézary cells, which are usually a form of CD4 cell too. So we use these proteins that are attached to the surface to sort them into groups. So cancer cells will stop making some of the normal proteins that we see on normal lymphocytes. So if this is a normal T cell that expresses CD4, CD7, and 26, then we can sort it by those, compared to the Sézary cell, which is no longer making the CD7 and the CD26. So we can count up how many of those abnormal cells there are, and then we grade it on a scale of 0 to 2. If we find no abnormalities, that's a 0. 1 is when there's a limited number of abnormal cells, and 2 is when we see more than 1,000 Sézary cells in a given sample. Then we take all of this grading we did and we plug it into this table to figure out people's stage. So the majority of people with mycosis fungoides are going to be stage 1A or B. These are patients who have just patches or plaques with no lymph node involvement, no metastases, and they can actually have some blood abnormalities, but it's not a significant number. The stage 2B are people who have tumors. The stage 3 are people who have erythroderma. And the stage 4 are patients who either have a lot of blood involvement, who have lymph node involvement, or who have metastases. Now, as I mentioned, prognosis depends on the staging, particularly for mycosis fungoides and Sézary syndrome. But because we don't have a perfect staging system for all of the different types of cutaneous lymphomas, we like to group them into 2 groups based on how fast they grow and how aggressive they are. So we talk about the indolent lymphomas, which grow very slowly. Treatment may not even be necessary unless it's causing symptoms or to prevent progression. And indolent lymphomas are sometimes not curable. Then there's aggressive lymphomas. They grow very rapidly. Treatment is necessary for survival, or these are the ones that can spread and lead to death and morbidity, and they may be curable with treatment. So the indolent lymphomas tend to be mycosis fungoides and a few varieties of other cutaneous T-cell lymphomas. And then two of the B-cell lymphomas called primary cutaneous marginal zone lymphoma and primary cutaneous follicle center cell lymphoma. The aggressive lymphomas include Sézary syndrome, and then a number of other T-cell lymphomas, such as the aggressive CD8 positive lymphomas, the primary cutaneous gamma delta lymphomas, and the peripheral T-cell lymphomas. Finally, there is one aggressive form of B-cell lymphoma, the primary cutaneous diffuse large B-cell lymphoma. Now, when we look at treatment of cutaneous lymphomas, we have two ways that we can go. We can direct the treatment at the skin, or we can direct the treatment at your entire system. So some of our skin-directed treatments include topical corticosteroids. Those are the topical steroids. We can also use intralesional corticosteroids. That's where we inject a steroid medication into an individual lesion. There's other topical medicines called topical retinoids. The most common used to treat cutaneous T-cell lymphoma is the one called bexarotene, and these are relatives of vitamin A. We have topical chemotherapy, which are topical medicines that kill off cancer cells. This includes nitrogen mustard, which is also called mechlorethamine, and rarely we'll use a topical medicine called 5-fluorouracil. And then there's topical immunotherapy. That's a topical medicine that stimulates your immune system to fight off the cancer. The main one that's available is called imiquimod. Then another very common tool in our tool belt for treatment is phototherapy. There's a number of different types of this. The most common is called narrowband ultraviolet B. There is another more potent form of phototherapy, although it's not widely available, called PUVA, which is Sorlin, which is an oral or topical medicine that's given, and then ultraviolet A light. And then there is a device called an excimer laser, which is a laser that produces ultraviolet B radiation. Finally, we have radiation treatment or X-ray treatment that can be done to individual lesions or to the entire skin of a person, called total skin electron beam radiation. And this is typically done by a different doctor, a radiation oncologist. Then we have systemic therapies. There's a variety of these. There's oral medicines that can be given, especially oral retinoids, which are pills that you take to help fight off the cancer. There is a medication called methotrexate, which is also a pill or sometimes an injection. There are injectable medications called interferons, which rev up your immune system to fight off the cancer. And then there are other medicines called HDAC inhibitors. There's an oral one called varinostat and an IV one called romidepsin that are useful in treating some cutaneous lymphomas. Then there is a treatment called extracorporeal photopheresis. This is used most commonly for people with T-cell lymphomas with some blood involvement. And this is a blood treatment where your blood is removed, a chemical is added to it, and it undergoes treatment with ultraviolet light and then is given back to you. Then there's true chemotherapy. So chemotherapy are medications that are used to kill off cancer cells, and they're somewhat nonspecific. So most of the time we use just a single type of chemotherapy at a time. The names of some of the more common chemotherapy medicines are gemcitabine or doxorubicin, sometimes called Doxil. And then we have targeted therapies. These are some of our newer treatments, and they target the specific proteins that are on the surface of lymphocytes or other immune cells. So some of these include brentuximab, alemtuzumab, mogamulizumab, and pembrolizumab. You'll see that they all end in AB, and that means that they're an antibody that binds to those proteins. Sometimes with very aggressive lymphomas, we use multi-agent chemotherapy. That's combining multiple chemotherapy drugs together to get a better response. I certainly want to mention clinical trials. These go on sometimes in private practices and also at academic centers. And it's where we study new treatments to see if we can find things that are better for treating. And finally, there are stem cell transplants and bone marrow transplants that are sometimes used for people with life-threatening disease. Now, with cutaneous lymphomas, oftentimes we combine therapies together. We'll use multiple systemic treatments, or sometimes a skin and a systemic treatment, or sometimes multiple skin-directed treatments to get added benefit and a better outcome. Now, how do we choose which treatment we use for patients? That can be very variable, and it may depend on the stage or the extent of the cancer, whether the cancer is causing symptoms. With cutaneous lymphomas, itch is one of the main symptoms that may lead us to be more aggressive if the itch is limiting your ability to sleep or function. The age of a patient, what we can use in a 30-year-old may be different than things that we would use in an 85-year-old patient. Other coexisting medical problems may make it harder for us to use certain treatments. Access to treatment can be a problem sometimes. Things like phototherapy that are done in the office of a dermatologist may not be close to some people's homes, or things like extracorporeal photopheresis is typically only done at academic centers and maybe hundreds of miles away for some people. And then also patients' ability to adhere to a treatment program. And I mean no judgment with this. So if phototherapy requires 3 visits a week and you need to work every day and you are unable to alter your work schedule, then that is not a good treatment for you. And we may have to look at alternatives. So thank you for your attention. I hope you learned something from this presentation. And I really would like to thank the Cutaneous Lymphoma Foundation for giving me the opportunity to speak to you about the basics of cutaneous lymphoma.